Using like new, they do so much virtual.
Hello, everyone who joined. This is Sai. I'm one of the neonatologists at Cincinnati Children's Hospital. Um, Thanks for joining today. We will wait for a few more minutes until 3 before we start this. Thank you. Okay. Good afternoon, everyone. Thanks to everyone who joined this afternoon to the AAP section of Neonatal Perinatal Medicine and TCAN co-sponsored virtual journal club. Today, we have the honor and pleasure of having Dr. Wally Carlo from University of Alabama and also Dr. Clyde Wright from University of Colorado to help moderate this session. And Zia Kabani, one of the fellows from University of Alabama, will be presenting the paper this afternoon. And I request everyone to please mute yourselves if you're not speaking. And if you have any questions while the article is being presented, please go ahead and type it in the chat box, and I'll help get those questions answered in the end. Thank you so much. And we are also recording this session. So for anyone, if you want to have future reference, I'll share the recording later. Thank you. Zia, you can go ahead and start. Thank you.
Okay. Hi, everybody. Thank you for taking the time and for giving me the opportunity to present this journal club today. Today, we're going to present one of the many different articles that came out from the support study, the early CPAP versus surfactant in extremely preterm infants. So I know Dr. Jane did this PICO statement last time. I just figured I would put it out there for us. So it's a randomized multi-center trial with a 2x2 factorial design. The population were infants born between 24 and 0 weeks gestation and 27 and 6 weeks gestation. The intervention, there wasn't really a placebo per se in this or a control, but the intervention was CPAP treatment in delivery room, and then the control or the, I guess, standard of care was intubation with surfactant. And then the outcomes that were followed was death or bronchopulmonary dysplasia as defined by requirement of supplemental oxygen at 36 weeks. And then it was really followed up longer than this, but for this particular part of the study, they were following up to 36 weeks. Interestingly, they also, of course, we know that the support trial also looked at oxygen sat targets. So infants were also randomly assigned to one of two target ranges of oxygen saturation, so 85 to 89% or 91 to 95%. And that was written up on a different paper. So in terms of background for this, the Cochrane Review talks about surfactant treatment at less than 2 hours of life, significantly decreasing rates of death, air leak, and death or BPD in preterm infants. The studies have shown that there's a decreased risk of chronic lung disease with early use of surfactant. And interestingly, many of these trials didn't have very high use of maternal corticosteroid therapy. And also, none of the infants in the control groups in these trials really received early treatment with CPAP. There was a growing observation that CPAP in very preterm babies with RDS could decrease the need for mechanical ventilation without an increase in complications. And then another Cochrane review in 2002 actually showed no significant reduction in CPAP group compared with the intubated group in rate of death or need for supplemental oxygen at 36 weeks, although there was a significantly higher rate of pneumothorax in the CPAP group compared to intubated group, mostly in the first 2 days. So the support trial, the surfactant, positive pressure, and oxygenation randomized trial really aims to compare early CPAP treatment with early surfactant treatment in extremely preterm infants. And then, like I said, they also randomly assigned infants to one of two target ranges of oxygen saturation, during their exposure to supplemental oxygen, although they don't, it's not addressed very prominently in this part of the article. So I'm gonna, throughout this review, I'm gonna be going through the consort checklist to critique whether the randomized trial met the criteria for everything. So in the title and abstract, the identification as a randomized trial in the title, they actually don't have that. And then the structured summary of a trial design, methods, results, and conclusions, that was, of course, done in the abstract. There is scientific background and explanation of rationale. And then they did state the specific objectives, but they don't actually state the hypotheses until much later in the article. The study design, so it is a randomized multi-center trial to compare the strategy of treatment with CPAP and protocol-driven limited ventilation that was began in the delivery room and continued in the NICU with the strategy of early endotracheal intubation and administration of surfactant within 1 hour of birth, followed by a conventional ventilation strategy. Randomization was stratified according to center and gestational age group, and it was performed before delivery, and infants that were part of multiple births were randomly assigned to the same group. And then the eligibility criteria, they were included if the infant was 24 to 27 and 6 weeks gestation at birth, was born without any known malformations at participating centers. The decision had already been made that the infant would be full resuscitation, and informed consent had to be obtained, and then they were randomly assigned within each gestational age strata, so 24 to 25 and 6 week gestation, or 26 to 27 and 6 week gestation.
And Zia, can I say one quick thing about that?
Sure.
Yeah, so in the introduction, you made a really strong case for why this study needed to be done, and the inclusion of those lower gestational age babies is another major reason, because the Cochrane review, if you look at those papers that supported prophylactic surfactant, most of those babies were kind of in the 27, 28, 29 week range, and as you indicated, did not see antenatal corticosteroids. So here we're looking at a completely different group of babies that are probably more relevant to the practice of neonatology today. High rate of antenatal corticosteroid use, and then those babies at very high risk of lung disease.
Yeah. Thank you for that.
Yeah, thank you so much for that point, Dr. Wright. And also, Dr. Carlo, if you have any input on some of the background and introduction that Zia has mentioned until now as one of the authors on the paper, please feel free to go ahead and jump in and please provide your input on that as well. Thank you.
Sure. So let me make a comment, because what Dr. Wright is saying is important, is the gestational age. We actually thought about enrolling 23 weekers. There was a pilot study that not a lot of people know about, but in the 23-week group, there was too much failure of CPAP. So at that time, I guess we didn't have so much expertise. Nowadays, people are extending it to 23 weekers, but the intention was to go to the lowest gestational ages possible, but we were afraid that it would be too much failure of the most premature babies.
Yes, I did see that. It was actually mentioned in the paper that the reason to not include babies in like the 22, 23 week gestation was because there was, there was concern for failure, but that in retrospect, when looking at data within units individually, they did find that there were some 23 weekers that succeeded. And, of course, we see that within our units as well. So continuing on. In the CPAP group in the delivery room, CPAP was administered by a T-piece resuscitator, neonatal vent, or equivalent device. Sorry, I'm like not even clicking. CPAP or ventilation with the PEEP of 5 was recommended, but of course, if needed, you could use higher. And if the infant needed positive pressure also, and then CPAP was continued until admitted into the NICU. If intubation was required based on standard indications, they were given surfactant within 60 minutes, and infants within 48 hours of life, within the first 48 hours of life, they did receive surfactant. And infants within this group could be intubated if they met the criteria of FiO2 greater than 50% to maintain SATs above 88% for 1 hour, or PaCO2 greater than 65 in a blood gas within 1 hour before intubation, or if there was hemodynamic instability like a low blood pressure for gestational age or poor perfusion, or both, especially if they were requiring volume resuscitation or pressure support for a period of 4 hours or more. And then the same thing, we tried to extubate the infants in the CPAP group as soon as possible within 24 hours after meeting criteria. And the extubation criteria was a PaCO2 below 65 with a pH higher than 7.2, SATs greater than 88% with an FiO2 below 50, and then a mean airway pressure less than 10, with a vent rate less than 20, or amplitude less than twice the mean airway pressure if on high frequency. Of course, we wanted hemodynamic stability and then absence of a clinically significant PDA.
Zia, I had a quick question regarding the PEEP of 5. The authors in the paper do mention briefly about a previous study which used a PEEP of 8 causing being associated with high number of pneumothoraces. And how is the number 5 picked, Dr. Carlo, while some of these discussions were going on at the initiation of the study?
Yes, so it's a good point. At that time, the study by Colin Morley showed that in the randomized control trial, they use a high end expiratory pressure from the beginning, CPAP of 8. And there was a concern that we were electively using it on patients and that we should start with probably a lower, just in case the higher CPAP level was what led to the increasing risk in pneumothorax. So it was initiated at 5, but it could be increased without restriction. The other thing that I wanted to mention is that Sia's mentioned the management of the CPAP group, and something really interesting is that you mentioned the criteria for intubation and the criteria for extubation. What's interesting is that the blood gases, like any abnormality with the blood gas pH or CO2 or FiO2, any abnormality would lead to needing intubation, or to indicate intubation, whereas if all 3 became normal, then there was no indication there was no indication to continue intubation, and they should be extubated within 24 hours. So it's really interesting. For example, if the patient needed more than 50% oxygen, surfactant was indicated once an intubation. And once the FiO2 dropped below 50 and the pH and PCO2 were okay, then they had to be extubated if they're on low settings. So this was the first study that had not just indications for intubation, but management for weaning and for extubation. And extubation was mandated within 24 hours. So it's very important in the context of how we extrapolate this to the practice, that it's not just initial CPAP, it's also what the article calls limited ventilation strategy, which really is another term for maybe like permissive hypercapnia. That was part of the study. The term officially in the group was limited ventilation strategy.
And Dr. Wright, do you have any comments on that as well?
Yeah, thanks, Dr. Carlo. I was wondering if you had internal discussions about a maximum level of CPAP amongst investigators. That's number one. And then number two, another difference between your study and the COIN trial was the inclusion of all infants, which you did, versus the COIN, which was just spontaneously breathing infants. And I was just wondering, what were the internal discussions about using that approach?
Yes, a very good point. So the internal discussions were that CPAP level could be increased. At that time, generally, it was not used more than 9. For example, the randomized trial by Bancalari used 7 to 9 as a high group for extubation, after extubation. I'm sorry, and you mentioned something, a second thing, and I'm blocking now.
Oh, the COIN trial just
Yes.
enrolled spontaneously breathing babies, but you enrolled every baby. And I was just wondering what the internal discussions around that design were.
Very important. Yeah, that's a very important distinction. So as much as we can, we could, we wanted to be very inclusive. So for example, we did not want to exclude a baby just because he was apneic, for example. He had to be managed with CPAP and try to get them to breathe. And if they wouldn't breathe, they had to be intubated, but they had to be extubated promptly. So yeah, ideally in randomized control trials like this, and you want to generalize the practice, you want to have a few exclusion criteria. So if I recall, the only exclusion criteria really was that the patient had severe anomalies. So generally, as a rule of thumb, you want to be very inclusive of the population.
Sorry about that. I'm also on service, so I'm getting a lot of calls. Should I continue?
Yep, go ahead. Thank you so much for that discussion.
So in the surfactant groups, like we said, infants in the surfactant group were intubated in the delivery room, received surfactant within 1 hour with continued ventilation. And again, the hope was to try to extubate these infants within 24 hours after meeting extubation criteria. And once infants extubated, they were treated according to standard practice in the NICU. The other thing that I thought was interesting about this was that the extubation criteria was a little more rigid, I think, or a little more stringent than the one for the CPAP group. So you had to have a PaCO2 less than 50, a pH higher than 7.3, FiO2 of 35% or less, with SATs of 88% or higher, and a mean airway pressure of 8 or less. And then, of course, a vent rate of 20 and an amplitude less than twice the mean airway pressure if high-frequency ventilation was used, and then hemodynamic stability without evidence of clinically significant PDA.
So
these
yeah,
babies-
this is important to comment here.
Yeah.
Because the control group, which is this group, no? The surfactant group is the control group. You also have to have criteria for weaning, for example. So obviously the criteria were different, the different levels of CO2, different level of pH. But the idea is that you cannot prove that an intervention is better if the control group gets less than optimal care. So the control group, the surfactant group, had to get like the best care, which included also aggressive extubation.
Right. The criteria was also in effect for infants for first 14 days of life, and then after which they were treated according to unit practice. That was for both groups. And intubation for both groups could be performed at any time for reasons such as apnea requiring bagging, shock, sepsis, or if they needed surgery. So, of course, for any clinical indication. The primary outcome, as we know, was death or BPD. And then BPD was defined as receipt of more than 30% supplemental oxygen at 36 weeks, or the need for positive pressure support, or in case of infants requiring less than 30% oxygen, need for any supplemental oxygen at 36 weeks after attempt of removal of oxygen. Then secondary outcomes was BPD defined as receipt of any supplemental oxygen at 36 weeks. And they also looked at pneumothorax, IVH, need for chest compression or epinephrine during resuscitation. The statistical analysis, sample size calculations were based on data from the Neonatal Research Network from year 2000, and they were able to get a target sample size of over 1,000 infants, so 1,310 infants. And analyses, of course, were performed according to intention to treat principle. And the primary analyses focused on the percent of infants in each group who survived to 36 weeks without BPD. Categorical outcomes analyses used Poisson regression and generalized estimating equation model to obtain adjusted relative risks with 95% confidence intervals. The continuous outcomes analysis used mixed effects linear models to obtain adjusted means and standard errors. And then, of course, results were adjusted for gestational age strata, center, and familial clustering. And two-sided p-values of less than 0.05 were considered statistically significant.
And if I could just say that the sheer size and scope of this trial was quite impressive. If you compare it to the COIN, it's almost double the size. And it just speaks to the effort that the people who designed the study put into this and really made it what it is and how it has impacted neonatal practice.
So again, going back to the CONSORT checklist and looking at the methods, I think they did a really, really good job overall in checking off all the check boxes. The only reason I gave a plus or minus for 8B was because they did have detail about the type of randomization, but they really didn't give any details about blocking. So, but that was, you know, otherwise it was done very well and noted.
That's a great point, Zia. No, one has to be critical, as you did with the title, that it did not include the word randomization. And one has to be critical. They did not specify the blocking. There is blocking. I can tell you, it's part of how we do the trials in the Neonatal Research Network. So you want to allocate them by blocks. This is mentioned, it's by center, but we did not specify the block size. But in part, so everyone understands why, because it's an open label treatment. People know it's not a blinded intervention. It's probably best if we don't tell people the blocking size. That's the issue. If we tell people, you know, there will be blocks of 4, then if they have 2 babies on CPAP, they know the next ones will be surfactant. So that's why, while that is the criteria, there's a reason why, you know, sometimes you cannot specify the blocking size to the investigators. Clinically, the Research Triangle Institute had blocking sizes.
Dr. Wright and Dr. Carlo, can you, as we are just done with methods and backgrounds, can you please comment and educate some of us, like on, as this was one of the really well done 2x2 factorial design study in neonatology, the thought process behind it and how it works best when it comes to looking at 2 different outcomes using the same study population for us, please? Thank you.
Yeah, that's a very important issue. I'm glad you bring it up, because factorial design is a complicated design, but it's extremely useful, particularly in this case. So the issue is when we change the ventilator support, let's say CPAP versus intubation, we are going to affect the FiO2 and the saturations. So this is the perfect situation where you control both then. And the beauty was that the saturation could be done totally masked. So the investigators were masked. You probably have all read about that study. The monitors were altered in such a way that they produce an offset. And the clinicians did not know which group of the patient was assigned to. So that led to a really good control of the saturations and the FiO2, because we did not know in the CPAP group, for example, or the surfactant group, if we were aiming for high saturations or low saturation in that baby. So we could not guess that it was because he was not intubated that he was needing more FiO2. for example. So that's a very, very important point. Plus also, that's what happens clinically. So if you change the ventilator support, then you change oxygenation. So it's a perfect situation to do two studies. There was a lot of controversy. So until people realized that this was the way to go. Importantly, the powering this trial for an interaction of the interventions is extremely difficult because the sample size would have to be so large. So as Dr. Wright mentioned, this is a very large study, well powered. It's the largest ventilator study. But it was not powered for the interaction of saturations and ventilatory support. At the end, there was no interaction really. So it also didn't matter. We did consider the possible interaction in terms of the effect size. So the effect size was reduced a little bit from what we would have, let's say, aimed or expected, but and that led to the large sample size that, let's say, compared to the COIN trial, this is twice as big.
Dr. Wright, any comments on that?
In neonatology.
We briefly asked you, go ahead, Zia.
I was just going to continue, but if you have something to add, go ahead.
Zia, I think you can go ahead. Mm-hmm.
Okay. So in terms of the results, so from February 2005 to February 2009, we know that over 1,300 infants were enrolled, and 565 of them were in the lower gestational arm, and then lower gestational age arm, and then 751 were in the higher gestational age arm. There was no significant differences between the two treatment groups in sex, birth weight, race, or ethnicity. And then the other thing was that the rates of use of positive pressure ventilation, or EPI, to treat persistent bradycardia was significantly lower in infants assigned to the CPAP group. And 32.9% of infants in the CPAP group did not receive surfactant. So that tells you that a good portion of them did receive it. They did end up getting intubated at some point. So if you look, this just says that positive pressure ventilation in the delivery room was, of course, a lot higher in the surfactant group. And then CPAP in the delivery room was, of course, a lot higher in the CPAP group. And then the surfactant treatment in the delivery room was a lot higher in the surfactant group. And in the delivery room or NICU, both were also a lot higher in the surfactant group. But my point was that you're still seeing a good amount within the CPAP group over the time of, the intervention.
And I think this is a key point as well that makes this trial a little different than the COIN, because in the COIN, if you were in the intubation group, you did not necessarily get surfactant. And so really by randomizing these babies to CPAP versus prophylactic surfactant, it really tested what was standard of care at that time, which was routine intubation and surfactant delivery in these tiny babies.
And then going on to other results. So adjusting for gestational age, center, familial clustering, there really was no significant difference in the BPD rates between the CPAP group and then the intubation and surfactant group. And there was not a huge significant rate between the group differences in rate of death or rate of BPD. So our primary outcomes had no statistically significant difference between the both, which is what I'm highlighting here. Although if you look, the group, the CPAP group actually had a lower mortality. I mean, they had a lower rate of death in general, their relative risk was lower as well. And then the secondary outcomes, so the top part, this is exactly the same table as the previous slide, but it's a little bit bigger. And then the top part we just talked about. But one of the first things that I think is important to note is the need for mechanical ventilation. Number of days was, of course, a lot less, significantly less, like 3 days in the CPAP group compared to the surfactant group. Survival within the first 7 days of life without need for any ventilation was also higher in the CPAP group, and this was statistically significant with a p-value of 0.01. And then the postnatal corticosteroid therapy for BPD, the need for that was also significantly less in the CPAP group compared to the surfactant group, which I think was also very, very important, with a p-value less than 0.001. And then finally, I think the thing that I was expecting, and I'm sure others were too, was that there would be a difference in the air leak in the CPAP group and surfactant group, and there really wasn't much. In fact, it seems like the surfactant group had more air leaks. And then in the post-hoc stratified analyses, they did find that infants in the lower gestational age group had lower rates of death at 36 weeks in the CPAP group, so 23.9 versus 32.1%, which is pretty significant, but that there was no significant difference in the rates of death in the higher gestational age group.
So Sia, this is important to comment. First is secondary analysis. Actually, the study is not powered for this analysis. So it's a little bit controversial whether it should be done or not. But the data are compelling for two reasons. First, a large effect size on an important outcome, mortality. But second, that the babies in the lowest gestational age subgroup had essentially all the benefit in terms of death. So it was compelling enough that, as you see, it's a post-hoc analysis. The study was stratified, but not powered for stratification. So we stratified the lower gestational ages, 24, 25 weeks versus 26, 27. So it's stratified so you get the groups balanced, but it's not powered to do this analysis. But the the authors thought we should highlight this result, and the editors allow us to include it actually even in the abstract. And this is an important outcome because this tells you it's not only the more mature babies this should be tried. Actually, the ones that get the most benefit may be the most immature ones.
That's a great point, Dr. Carlo. On the same lines, I was going to ask you, in the context of these results, would you please comment on the hypothesis of the study? Like when you were designing this study, were you expecting that CPAP would have better outcomes, or were you trying to tell us all that CPAP was equivalently good enough compared to surfactant in the delivery room?
Yeah, we designed the study as a superiority study, that CPAP would be better. At the time, that was extremely controversial, but there were case series of showing that babies treated with CPAP did better than treated with surfactant. But obviously, as you all know, at the time, it was a standard of care to give surfactant. In fact, people wanted to give it early, intubation soon after birth. But then several observational studies showed that managing the patient with CPAP instead of surfactant actually led to better results. Looking at the post-hoc, after the analysis, looking at the results, obviously we were disappointed that the effect size was not bigger. So take death or BPD, and the best definition is the physiological difference, but the other definition is important because of the masking of the oxygen administration or oxygen saturation till 36 weeks. So there was some overlap with making the diagnosis of BPD. So if you look at the need for oxygen supplementation, it was close to significant. And no, sometimes, and I like to highlight this with the group, is that you do the right study, and ultimately, obviously, it would be better that you show significant benefit, but this just was the first study showing that there may be benefits of not intubating babies and giving them CPAP instead, and the management with permissive hypercapnia, limited ventilation strategy. And what happened then? After that, Vermont Oxford published their paper, which also showed similar trends, not significant, but when you do the meta-analysis, then it becomes significant. So do the right science and don't worry if the results are not ideal, let's say. As you can imagine, the study is done in multiple centers where there are many physicians that comply more or less with the protocol, but that the fact that you can generalize the results to all the centers, that's very important. That independent of the practice in one center, it has trends for benefits in all the centers. That's very important.
And if I could just say one thing, you know, the findings here that CPAP was safe and there might be a signal towards benefit really brought routine application of CPAP in the delivery room to these babies. And I know I keep mentioning the COIN trial. Again, that was published a couple years earlier in the New England Journal, but CPAP wasn't widely adopted after that trial for a couple reasons. One is that they used higher levels to begin with, CPAP of 8. That was one. And then two, and we may mention this later, there was a higher risk of air leak in the CPAP group. So those two things alone, I think, really gave practitioners pause. And it wasn't until this study was published that CPAP really caught on.
Excellent points. Thank you. Zia, you can go ahead.
So again, we'll go through the consort checklist, and again, the authors did a great job. I didn't put the participant flow diagram on here, but there was one, and everything was done as needed to be for the results. So basically, when you look at the discussion and you look at the conclusions, there was no significant difference between early CPAP strategy and intubation and early surfactant strategy on rates of BPD and death. They did talk about there being the limitation that there was a high rate of intubation and surfactant treatment among infants assigned to the CPAP group, but that was expected, and the crossover was planned for ethical reasons. You know, we did this in an intention to treat analysis, and the infants were treated the way they needed to be treated. And then there was no significant differences in rates of pneumothorax, even though I think people expected there to be IVH or need for chest compression or epi administration in delivery room. And then the secondary analyses showed significant reduction in risk of death in the CPAP group and smaller gestational age group. And like Dr. Carlo said, and it was mentioned in the study, because this was not powered for this stratified analysis, we really should take that with a grain of salt, and that needs further evaluation and testing. But I think when it comes to generalizability in our unit, we definitely, you know, do CPAP on a lot of our smaller babies, and a lot of them do just fine with it without need of intervention with intubation and surfactant treatment. So I think the study, like all of you have already recognized, is such a landmark study in how we practice ventilation strategies in the NICU, especially in our most vulnerable population. So that is all I have. And then again, looking at the consort checklist, met everything. They did have the registration, the protocol, and the funding, and they did talk about limitations. I feel like they didn't specifically talk about generalizability, but I felt like we practiced it so much that it was clearly generalizable. So that is it. Thank you for your attention. Questions, comments, Dr. Carlo, Dr. Wright.
That was very good, Sia. And one thing to highlight is you said the crossover. So they were treated, let's say they were intubated. Obviously, some patients would need to be intubated, but they still remain in the same group. So they were intubated, but they remain in the CPAP group, which had the management algorithm for rapid weaning, or let's say extubation, early extubation at higher CO2, lower pH levels.
I have a couple of questions from some of our participants. So one question was the type of surfactant used at all these different centers. Like, was it the same kind of surfactant? And the second question was regarding the consent for this study, which was also one of my questions too, as in, all these major trials, like we do, at least in the past, had either death or BPD as one of their primary outcomes. And when we approach families, if I don't really know how we would be able to consent any family, even if we remotely mention death as an outcome that we would be looking at. So like, how is that approached during the study? And so if you want to comment on that too.
Yeah, that's an excellent point. And also, even before you consent the parents, let me tell you, when you tell the IRB that you want to do a study that you're looking at death, oh my God, they're going to be very uptight right away, you know? So, and obviously, this is a very high risk population with a high rate of mortality. So if you only said BPD, it could turn out that you can reduce BPD and maybe by increasing mortality or through increased mortality. And then you would conclude that there was a reduction in BPD, but there was really an increase in mortality. So one has to be careful always with this. There's an example of an adult study on control of glucose. And the intervention was a very tight control of glucose, and it's the primary outcome, and it showed it improved glucose control. But the problem was, as a secondary outcome, was the mortality, and it also increased mortality. So that's why it's important to think of the primary outcome as including mortality when the patient population is high risk. This is actually a very controversial issue. I can tell you that I got so many emails on these experts throughout the country, expert in trials, not in neonatology, but expert in trials, questioning why you would include mortality. So it's some people call it a competing outcome, although that term is used more in neonatology than in the adult literature. But if a baby dies, he cannot get the diagnosis of BPD, for example, if he dies early. So that's the issue. When you get consent, yeah, to your question about how do you approach the parents for consent in these critically ill patients, it's a big issue. But usually the best way to explain it to people is that we have a standard of care, which is in this case surfactant, intubation and surfactant. But we think we have an approach that would be better, and it may lead to less death or BPD. And we tell them there's some evidence for this, but it has not been done in a controlled fashion. There's only case series in which people have tried this approach, and it seems to be better. So another way I tell the parents and also the staff in the unit, the nurses, we never try to test a worse therapy than the usual. So we never try to compare standard of care versus something that is worse or expected to be worse than standard of care. So if the parents agree, then you're trying to do something better than standard of care. In addition, many times we don't find significant benefits, like in this case. There's the Hawthorne effect that has been shown in many studies in which there's a benefit for both groups for being in a randomized controlled trial. So because of many issues, let's say more oversight, for whatever reasons, there's a better outcome. So that's a benefit of being in a randomized controlled trial.
Thank you. Excellent points. Dr. Wright. We can't hear you if you're speaking.
How about now? Can you hear me now?
Yes, we can. Mhm.
Okay, sorry about that. I just wanted to say for everybody who's preparing for boards, what he's describing is a competing outcome that might show up. So obviously you can't have BPD if you're dead, and it's why it's so important to include in these trials of high-risk babies.
Great point. There's another question from the audience on in any of your secondary analyses, did you see any correlation with the number of days that baby was intubated with development of BPD in either of the groups?
Yeah, so that's an important question. Is to what extent, let's say, you can do secondary analysis. So so generally there's a primary outcome, like in this case, death or BPD. Then typically you report the components of the primary outcome as secondary outcomes, and then you think of other secondary outcomes. They generally have to be pre-specified. So it's rare that we can do good or high level of evidence studies with exploratory analysis. So we have to be careful. So in general, we cannot or we should not do exploratory analysis. And especially in a randomized control trial, you don't want to undermine the randomization. So let's say what would be not ideal is if you start analyzing the data by how many days on a ventilator, independent of group, because then you introduce bias from the sickest patients being on longer time on the ventilator and then having the worst outcomes. So you would find associations such as duration of ventilation being associated with worse neurodevelopmental outcomes. But that would be as expected. And then there's a lot of unexplained variance. And you want to try to minimize any type of that analysis. And sometimes, let's say in the Neonatal Research Network, we've made our share of mistakes by doing that. For example, let me tell you, we published a paper of the patients that were not enrolled in support. And I guess the conclusion of the paper is that they were different to the ones enrolled, but that's known for almost every study, that there are biases. For example, the ones enrolled in support, you will have time to get antenatal consent usually. The ones that came fast and deliver fast, they would be less represented in this enrollment. So yeah, there will be always differences between patients enrolled and not enrolled in trials. So one has to be careful about doing that type of analysis.
So I had a question for Wally and Clyde. So from this trial, we know CPAP works pretty good, but I think the optimum level of CPAP to start with is still unknown. Whether should we start with 5 or 4, or should we start much higher CPAP? And I know there have been studies looking at variations, at least in mechanical ventilation, that people all over the country use various level of CPAP to start with. So are you aware of how are we trying to address this question? Are there being trials designed for this?
I think the best way would be to do randomized trials, but there's one trial that was done after extubation. So what CPAP level should be used after extubation in babies with RDS? There's such a trial. The last name, I think it's Bolivar, and the other author, Bancalari, and they randomized patients to receive 4 to 6 of CPAP versus 7 to 9. And you see that may be a wide range, but that was the design of the study. And they had, the primary outcome was meeting criteria for reintubation. And that differed with the group randomized, the infants randomized to the higher CPAP level, having less reaching reintubation criteria. That's the way they did it to avoid the bias from clinicians in intubating or not intubating. So they just said, meeting criteria for reintubation. So there's some evidence that after in RDS, after extubation, higher CPAP would be better than a lower CPAP level.
Yeah, and I agree with Dr. Carlo. It would be nice to have a randomized controlled trial, but it's going to be hard to envision somebody having the time and the money to do that. But I think what we do know from these trials is if you look at the COIN, increased risk of air leak starting at 8, and there they used reportedly maximum levels of 10. With this trial we went over today, starting at 5, going up to 8 or 9. I think the sweet spot is probably in that window, and you just have to look at the individual baby and the lung recruitment, work of breathing, and where you are in the time course of their RDS/early need for respiratory support.
Yeah, Dr. Wright makes a great point that these studies, well-done studies, take a lot of resources, and we cannot keep waiting for more evidence to let's say, to implement the practice of CPAP. For example, the mistake would be saying, we don't know how much CPAP to use, so I want to keep intubating and giving surfactant. So that would be a mistake. So it's like, perfection would be the enemy of progress. And that would be an example. And there will be other studies that will be done and trying to determine what's the best CPAP level. But at this time, the evidence is that yes, CPAP is better than intubation. So this is a better approach.
Dr. Carlo, if I can ask a question. Your trial was done not long after the AAP put a moratorium on dexamethasone use, and you found a decreased need for postnatal steroids with CPAP. How exciting was that finding to the investigators?
We were very excited. We thought that was an important finding in view of the concerns about postnatal steroids. And I think maybe the concern for postnatal steroids have been overstated maybe a little bit, but the reduction of, but that's an important secondary outcome, is the reduction of the use of steroids. It also indicates that the patient is not so sick for such a long time, So these are real clinical surrogate measures that indicate better outcomes. So there were a lot of, even though the primary outcome did not differ, there were a lot of surrogate measures of improvement, and also as well as process measures improvement. So how we can manage patients on CPAP in the delivery room, how that improved by trying to manage them on CPAP. If you intubate, yes, 90% of them need intubation. But if you try to keep them off, only a third need intubation in the delivery room. So that's an important process measure that we want to track during such trials like this.
Dr. Carlo, one of the audience's question was, if you had to redo the same trial again, how would you change it and what would you do differently?
Oh, that's an interesting question. Okay, so let me tell you. So in retrospect, we thought the effect size was not as high as we would have expected. So, and then no, that led to the not significant trend for improvement. But when you're changing a practice like this, there's a lot of uncertainty there if it's the right thing to do or not. Some clinicians would get concerned and just intubate. And that's understandable. I think we want the best care to the patient, and the physicians can override the protocols. So I think how I would do it better, it could have been like doing a much larger study, 2-3 times bigger. But no, we don't have the systems in place to do such large trials. They're very costly. But I making the plea for well-powered studies. So let me tell you one that we're doing right now. We're doing a study with administration of extending the caffeine administration for days beyond the apnea resolution. It's called the MOCA trial. You may find it in clinicaltrials.gov. And whereas most studies on apnea have had less than 100 patients, generally less than 50 patients even. And the largest study has been maybe 300 or so. This one will have 1,200 patients. So I'm making the point for well-powered studies, important outcomes that will result in changes in practice if they show a benefit.
That was great. That was great. Any last comments for the trainees who joined us today, both Dr. Wright and Dr. Carlo, and any piece of advice, even when it comes to clinical application of some of these great studies?
So I would say we have to embrace change. Let's say back in the early 2000s, it was like the standard practice to give surfactant. In fact, there were efforts to give it early and early, fast, all patients. Increasing gestational ages, babies of increasing gestational ages were getting surfactant. And sometimes think back and think if there are better approaches to care, and be open-minded as clinicians, be part of research, embrace change, and keep learning. I can tell you I'm still learning so much.
And I would echo that. And I would say, embrace the change to create new questions. And I think now that we're using more CPAP in these tiny babies, newer questions that didn't exist before have arisen. Things like how long do you try to maintain CPAP before you intervene with an intubation? There's a lot of debate around that. I think there's a growing level of debate around how long you keep these extremely preterm babies on CPAP. Does it enhance lung growth? Are we ultimately causing damage if we don't wean fast enough? So there are a lot of unanswered questions. And I would just remind people that we still have much to learn about how to care for these tiny babies.
Excellent, excellent. Thank you everyone who participated. I first want to congratulate and also thank Zia Kabani, our wonderful fellow from UAB, who did a fantastic job today to present this paper. And special thanks on behalf of AAP TCAN, as well as AAP section of Neonatal Perinatal Medicine Journal Club, to Dr. Carlo and Dr. Wright for making this happen and having a fantastic discussion on this groundbreaking trial. Thank you so much. We appreciate all your time and input. Thank you all for your participation.
Thanks to everyone.
Thank you. I enjoyed it.
Thank you all.